Ladies and gentlemen, it is a pleasure for me to have the honor and the possibility to speak in front of you and to share all the mine materials. First, I want to thank Dr. Ho, Mr. Lee, and Mrs. Young for having invited me. I am really honored. I want also to underline that I'm here not to teach you something, but just to share with you my knowledge, my experience. And I want to tell you that my webinar will be divided into sections, and we will continue the second part on the next Monday. Just a second that it starts. Okay. Sometimes I like to start my lecture with this slogan: everyday quality dentistry. Every day I want to say that I would like every day to have a quality in all the cases, not sometimes something of quality to show to the lecture and the rest of the day some bad work. No, every day. My dream is to have an everyday quality dentistry, and for me this is a very nice slogan, and I use it, I try to use it for all the day. We could say that the prosthesis is easy only if you know what to do, only in this situation. For example, despite this, many years ago, a lady came to my office asking me an opinion on her frontal teeth. And as you can see, my opinion was absolutely bad. At a close view, it is easy to see the bad quality of this work, I believe, for everybody. Both the technician and the dentist did a bad work. So I asked to the lady how much did she spend for this teeth. And I told her that they were worth the expensive. She spent less money and she had a very bad work. And in the end, she didn't want to replace them. She liked them. She just wanted an opinion. So we are searching for quality, but our quality is not the same for all the eyes. For this girl, this was quality. Talking about of implant, or better, prosthesis on implant, the problem where is? The problem is the soft tissue management. Because the prosthesis is done by the technician, we have to find a nice technician and to collaborate with him, cooperate with him as is possible. But our work is to create nice soft tissue. And here we can see two similar cases. In both the cases, the papilla is not well represented. The tissue are inflamed. The result is not correct. As you can see, I'm trying to use my curve. Here, there is not the papilla. The tissue are really inflamed. The papilla is missing, and in both the cases, the problem was the placement of the implant on the lateral incisor. They have not placed the implant in the correct position. So, to have nice tissue, we have also to place the implant in a good position. Another example. The teeth are not nice at all, I believe, for everybody, but if you move up the lip, they are also worse. The implants are not well placed, it is evident. The prosthesis is a terrible provisional one. It misses completely a study of the case, a planning. We must remove, to solve the case, we must remove some implants and start it again with a new prosthesis, a new work. We have to change everything, but we have to change everything because the preceding doctor didn't have a treatment plan, didn't study a treatment plan. Another one, the implant on the lateral is in a bad position. He is too vestibular, too buccal. And in this situation, you can see the metal of the components. But there are also other problems. The ceramic is a bad ceramic, is not nice. The median line is deviated, is not vertical. We have a lot of problems. The tissue are inflamed, too thin. So there is no harmony. The frontal composition is worse. We have to change everything, but we have to study the case. So to change the patient in this direction, I have removed the implant. I have placed a new one with contemporary buccal bone regeneration in the same day, logically. And in the same day, Giuliano Garlini, my friend, he spoke last week, corrected a root fenestration on tooth number 21 with the use of ProRoot. And then we made new crown and a new completely treatment plan. Now, the smile line is pleasant. Now she is satisfied. She can smile with happiness, and everything is proportionate. So, at the end, what can we do? In every situation, in all the situations, what can I do? I can use Photoshop to have a nice presentation, but I will have no patient in my office. Or I can study the case. I have to study the case. What I mean? I mean that a patient, a lady, an old lady came to my office. She told me, I don't like my teeth, and it's true, they are not nice. So I have to study what to do. The tooth were lost for period problem. And so with the use of DSD, for example, like in this case, I gave an idea to the patient of what I could do, and then I take all the information with the traditional method, some imprint, some impression. Now I use digital. At that time, I was using the stone model. I registered the face bow, and then the technician mounted the cast on the dinar articulator. And with all this amount of data, my technician was able to create a surgical guide. The surgical guide, as you can see in this position, that I used during the surgery to have an idea of where to place the implant in a correct position. In this case, I placed 6 immediate implants. I took an impression, and in one day, my technician gave to me the first provisional restoration, a screw retained provisional restoration on 6 implants. These are the implants, and this is the patient 2 days after the surgery, or better, 36 hours after the surgery, just at the end of the screwing. And this is her smile 36 hours from the surgery. The smile, you can see, is already nice, and I was able in a few time to satisfy the lady's desire. I spent more time to study the case than in doing it. And this is what I like to do. Without the project, it's difficult to get an objective. So the study of the case, in my personal opinion, is mandatory to avoid some error, for example, like the nest. This is a young patient, too young when somebody places some implant in his mouth. Then the patient grow up around this implant, but they remain in ankylosis. So when he came to my office, he was in this situation. Now you can well understand that you have to replan it, to restart again with all the treatment, and probably to remove the implant or to do some block section to take out the implant with some bone around it and to replace in another position. But in every case, it's a very difficult work because it was not scheduled in the correct way. But he is not the only. Another patient, she's a very nice lady, an MTV presenter, but the implants, she received this implant in the USA, the implant were too close between them, so she lose a lot of bone, as you can see. They were not able to charge the medium implant, and what it's happened was that she lose the interproximal crest and she lose the gingival profile. So from an aesthetic point of view, a tragedy. And what we can do now? If we want a perfect result, we have to remove the central implant, but it's very difficult because they are too narrow, they are too close between themselves, and it's a very difficult job. She's not the only, unfortunately. We have already seen this case with my friend Giuliano. It was an immediate load with an immediate error in implant placement. Then Giuliano has to work a lot to do something of nice. Or other case, she were using a flipper, and you say, why do you use a flipper if you have a lot of implant inside you? The reason was that the implants were not well placed. They were placed in this direction. And then another time, Giuliano has a lot of work to make her pleasant. So we have to remember well that the teeth moves every time. There is a so-called craniofacial growth, and it lasts all life long. But the implants are in ankylosis. They don't move. So we have always to take in mind this fact. And we believe to know everything, to don't do any mistake, but it's not so. This lady is a patient of mine, and she received an implant on the left central incisor with a JBR and the soft tissue graft many years ago in the 2000. Then she was in another city for 5 years, and she came back to my office 5 years later. She was adult. She wasn't an adolescent girl. And when she came back to my office, she appeared in this situation. And at the first look, we believed that the left central incisor grew up. But if we take a look at a close vision, we are able to see that all the mouth of the girl grow, apart the main teeth, because it remained in the same position. So, what was the solution? The solution was to change the crown, but the patient didn't want to do that, and she remained with a shorter crown, and until now, she is in the same situation. I passed a lot of years, 21 years from the first picture. The situation is worse now because the other teeth are moving anymore, but she's happy in the same way. So this is a mistake made by me. But after this publication of Daftari and Bahat, I'm seeing again a lot of patients, and I see a lot of movement of the teeth and not of the implant. Like in this case, the contact point between the tooth on the implant and the natural tooth during the year is moved. It changed. Another patient, 2006, 2014. The right central incisor is an implant. It remained in the same position, but the patient, it was 50 when they received the implant. It was not young. So the same problem also in adult patient. So what I have to do, because situations like this are very frequent, as you can see in other cases, 2002, 2019, the patient grow, the implant remain stable. What do we have to do? We have to tell to the patient, honestly, today the tooth is very nice, but in a few years, I don't know, because you are still growing, the tooth doesn't move. So we have to inform the patient. We have to tell him everything, because if this situation will happen, the patient could say, yeah, doctor, you are right. You have already said me that it could happen, and is almost normal. We have to do all the information, to give all the information to the patient as is possible. But now we live in the fast food century. Just the COVID stopped us, but we want everything immediate. Implant immediate, prosthesis immediate, success immediate, food in my house immediate, information with the computer immediate. We want everything immediate. So every time it is possible, we prefer to do immediate implant. Or better, in my practice, immediate implant is my first choice every time I can do it. But in a second time, a lot of nightmares. The monster will arise in my night. The only possibility that we have is to do an extreme case selection, patient selection. Not all the patients are equal. We have to choose between the patients who can do this treatment and who cannot do this treatment. So accurate extreme case selection. This is the only way that we have to avoid failure. And every time we have the possibility to choose between immediate loading, early loading, or conventional loading. Every time we have the possibility to choose. And one secret is to use the right component, the right device, because not all the implants are the same. Somebody works better, and we have to choose the one who works better. So an implant like this is very, very nice in my eyes because it works well in all the situations. Its property, one of its property, is to be able to reach high primary stability immediately, thanks to its particular design, and to maintain it during the healing in a best way, and above all, to reduce the stability dip during the first and the second week. So it maintains a very good stability also in the first time when normally we can see a decrease of the stability. So this implant, in my eyes, has many, many advantages in comparison to other implants. Today, in 2020 years, we can choose to do whatever we want, as I have already told you. So it only depends on the patient clinical situation or on the patient clinical selection that we do. So we can use short implant, we can do post-extractive, we can do functional loading, immediate loading, we can use digital dentistry, CAD/CAM, custom-made abutment, guided surgery. We can use a lot of devices, a lot of new tool. We can do what we want, but on the basis we must know the healing principle and we must know what to do. Without the treatment plan correctly scheduled, we can use whatever we want, but the result will not arrive. Yesterday, we didn't have all these tools and our knowledge were different from today. So when I saw a case like this, what I did, at the close-up, I saw that the left central incisor was to remove. His parabola was higher in comparison to the adjacent teeth. So I had to remove the tooth and to move down his parabola. And at the time, I wasn't able to do this in one time. So I decided to delay the loading of the implant. So I remove the tooth, I extract the tooth, I place a temporary Maryland restoration. I took it far from the gingiva because I don't want to give to the gingiva any compression, because I wanted the gingiva could heal going down, because my objective was to move this parabola in the incisor direction, the exact contrary of the ovate pontiff that you use in prosthesis in the normal case, when you want to push the tissue away. 3 months later, you can see the healing. The parabola just move a little bit in the incisor direction. Now we are ready for the surgery. I place an implant. I don't insert the implant inside the bone. I took it a little bit out. Why? Because I positioned the implant more or less 3 millimeters above the gingival margin from which I want that my tooth will exit in the future. So I regenerated all the bone with some heterologous bone and some autologous bone mixed together. I just use a reabsorbable membrane and suture my flap on it. Already at this time, it's easy to see that I move down all the tissue. I have started to move down the tissue. 6 months later, now it is evident the difference between the right parabola from the left. I have a lot of tissue to spend. The main gingival line is down in comparison to the other two. So I can spend some tissue to obtain a nice result. I reopen the implant, I graft some connective tissue harvested from the palate, and I close again. I close the flap for 1 month. 1 month after, I reopen with the T reopening. Is a technique that is made for preserving the soft tissue, and is in all case, it was a cemented crown. Now I use only screw retained crown, and this is the final result. As you can see, with the staged approach, I was able to move down the parabola. Now she is more down than the adjacent, and to get a nice result, probably not aesthetic, but aesthetic for the patient, because it is almost identical to his personal tooth. And we do the same in the posterior area. We extract the tooth, we wait for some months. Generally, we use 3 months. At the 3rd month, we place the implant, if it's possible, with the healing cap in the first time, with screw. And in the second time, we took the impression and then the tooth. This is the conventional way to move. But what have we learned in all these years? We learned that post-extractive implant, with or without immediate provisionalization, now, in my practice, is the ideal solution. Remembering very well, if the initial conditions are not ideal and no maneuvers are implemented to preserve the tissues or to improve the tissues, the immediate post-extraction loading fails in preserving the site. To place an implant doesn't preserve the site. There are in the literature many articles about this argument. I have taken this one is from European Association for Osseointegration. They are their consensus conference, and they asked, do you believe immediate implant placement after tooth extraction will be more frequent, similar at the time in 2019, or less? And most of the people answer that it will be more frequent. So it is an habit that will become more and more used. Another question was, do you believe immediate loading protocol will be more frequent? Yes, everybody answered yes. Always in the same situation. Did you find any difference between immediate implant placement, immediate loading on the early? And the answer was not. The two protocols are very similar for the results. So the only contrary that I have read is that most of the people say that immediate implant is only for expert operator. So they say that if I want to be sure about the aesthetic result, immediate implant with immediate provisionalization is not the first choice. I don't agree with this paper, because when I want to preserve, when I want to maintain, when I want to get an immediate result, a better result, and I want that my tissue will remain in the same position, logically, if they are nice when I start the case, for me, post-extractive immediate implant and immediate restoration is the best. But we are not all the same, and I want to show you all the ideas. But also, if I have this belief, not always it is possible to respect it. In this case, for example, with a permanent canine in a wrong position and with a patient who refused ortho treatment, what I can do is not a nice situation to perform an immediate post-extractive implant placement. The tissues are not well, there is a lot of inflammation. So I proceed in a staged approach. In the first time, I extracted the canine. I cemented a new temporary Maryland. I wait for 3 months. And as I'm used to do at the third month, I placed the implant. There was a very nice, a very big fenestration, so I harvested some bone with the ACM drill in the mouth of the patient, in the mandible. And then I positioned the autologous bone just on the implant. I covered the autologous bone with some heterologous bone, and I placed a non-reabsorbable membrane to titanium reinforced to maintain the position and the shape of the root of the preceding tooth. Then the tissue were very thin, so it was very important to passivate them in the best way. And I waited for 6 months before to reopen it. At the reopening is visible a lot of bone, a lot of new bone. I placed some connective tissue, a healing screw, and 1 month later, a provisional restoration. As you can see, the provisional restoration creates a lot of ischemia, a lot of compression. Why compression? Because I want to move the soft tissue in the direction that I want, where I would like that they go, because I want a natural tooth, not a conventional tooth. So in this case, some compression. Other thing to observe with attention is that the provisional restoration has a concave profile. I always use concave profiles in my components, in my prosthesis, and I always like to use platform switched implant like this one. 6 months later, the tissue are completely healed. As you can see, the papilla here was not present, and here it is present again. So just waiting and giving to the tissue the right space, the tissue normally react in the right direction. And this is the appearance of the patient with the definitive restoration sometimes after. I believe that her canine is very nice, is similar to the natural one, and from a conventional position, if you don't stay too close to the patient, is almost impossible to distinguish the natural canine from the ceramic one. And I believe that Samantha could be very happy about her treatment. And of course, I'm surely happy. And I would like that all my treatment would have this result. And this is the final X-ray. Another case in which it was not possible, or better, it would be possible, but I decided to delay the implant placement. I have to change all the crown of the upper jaw of this patient, and in the same day to change the crown, to place the implant. Probably it was too much work for me and for the patient, so I decided to delay this treatment. With the provisional on the patient, I extract the canine. The canine had a fracture on the root. It was not possible to save it. And also at that time, I decided to not do an immediate post-extraction loading with immediate implant placement, and I decided to do socket preservation. So some heterologous bone inside the socket and the punch, a connective epithelial punch to close the socket. I replace the provisional, I wait for 4 months, and 4 months later, I insert the implant. Here you can see a very, very special instrument. I know that Giuliano has already spoken about this instrument. For me, it is very special because I'm the inventor and I love it. It's called implant misura, and MR is the acronym of my name. It's produced by LM Dental, and the style Italiano. And it is very useful to take the correct distance between the first drill to the adjacent root to not mistake the implant placement. We can see it again in another picture in a better way. At the end of the surgery, I repair the provisional that I broke during its removal, and I replace the provisional in its position. 3 months later, I remove the whole provisional and I place a new one provisional crown is a screw retained crown. You can see also in this situation, or better, always the concave profile that I like a lot. And here is the provisional just screwed. You can see the amount of pressure that it gave to the soft tissue. The soft tissue are white. We have to wait for more or less 10 minutes, and if the white disappear, my provisional is okay. If the white tissue remain, I have to remove the provisional and to reshape it because probably it is giving too much pressure. Take in mind the papilla is not present, and we can see some months later how the correct provisional, the correct implant placement, the correct presence of the bone peak the mesial and the distal peak of bone. The correct job, the correct shape of the provisional restoration has given the possibility to the tissue to, to reach a nice contour. Now this is a normal tooth. It's a very nice tooth with a nice papilla and a nice parabola. So this patient moved from a situation that you can see on the left side of the screen to the central side with the new treatment plan, new prosthesis, and the close-up of the canine with a very, very, very natural gingiva. My goal was completely fulfilled, and I was very happy of this result, and the patient too, fortunately. This is another case, root perforation. The tooth has to be extracted. But what do you see? The patient missed a stable occlusion, and so it would be impossible to maintain out of the static and dynamic occlusion the implant restoration. So we decided to delay the implant insertion, the implant provisionalization, because if you don't have a stable occlusion, it's difficult to maintain safe our work. Another case, root fracture. We have to extract the tooth. We decide to do an immediate post-extractive implant with immediate restoration, provisionalization. But we wrong something. I wrong the implant that I use. In this case, I use an implant too aggressive and too wide as diameter. As you can see, the buccal bone plate is very, very, very thin. It's well represented, but it is thin. I open a flap because before inserting the implant, I have found a perforation, a fenestration of the bone. But what's happened? During the insertion of the implant, I broke completely the buccal bone. So I had to change my treatment plan. The primary stability was not so good, in my opinion, so I decided to regenerate the bone. So I harvested some bone from the nasal spine. I mixed it with some heterologous bone and covered it with the collagen membrane, and to suture a punch of epithelium connective tissue harvested from the palate, and to wait 6 months. Then I did a very, very, very little reopening, as you can see. I took an impression and I asked for my technician for a provisional screwed crown, always with a concave profile, as you can see. And they changed in the same time the provisional on the lateral incisor. This is the provisional just screwed, just cemented. As you can see, the distal papilla is missing. But if we do all our jobs in a correct way, it's just time to wait. And after, I believe, 6 or 8 months, I don't remember exactly, you can see how the gingiva will get a nice contour around our tooth. We will always miss the distal papilla because the crown on the lateral was too deep inside the tissue. But I believe that we have to be happy. We took an impression. Also in this time, we use the INS method to give an exact replica on the transmucosal path to the technician. And this is the final restoration. I have to thank my technician because the final restoration is very nice. It's almost impossible to distinguish the left from the right central incisor, and the patient was very happy with this result. We can see the very, very nice tissue that we were able to create. So, to make a long story short, I have difficult to remain seated, as you can see. We have two possibilities, two different treatment plans. We can do delayed implant or immediate implant. With delayed implant, we have to recreate what was there. With immediate, we can preserve what is there. So we have to choose, and you already have understood well what I prefer. The rationale for which I prefer immediate implant is that we can preserve better the bone, we reduce the risk of papilla loss, it is easier the management of the provisional restoration, and we reduce the treatment plan, so less surgery, faster healing, and the patient is more happy. And even if the patient not always have the same perception that we have for the aesthetic. This patient is very happy with their tooth, both the right and the left side of the screen. When I saw this patient, I was happy because I was believing to restart again with a new job, to do what I know, to give a nice result, but all the patients were happy. So we spend a lot of time, but sometimes the patient doesn't appreciate as us what we do. So what I do, immediate or delayed? If I give a look to the literature, they say that immediate load maintain very well the papilla, but not the parabola. Opposite, the delayed load maintain the parabola, but less the papilla. What is the truth? The truth is that they are very similar. The only problem is that the median loading is more technique sensitive, and the median loading is a little bit better in maintaining the parabola and the papilla. So every time that I can, I do immediate loading. Tidu Mancu, a lot of time ago in 2004, said that the alveolar gingival and interpapillary fibers preserve the interproximal bone peaks when to the interdental peri-implant tissue is given an immediate support by the use of a kneeling screw or an immediate provisional. Doesn't matter. The important is that you give a support to these fibers. Mauro Merli, a friend of mine in Italy, he said more that the use of flapless technique is the first choice every time he can use it. Every time we have a primary stability that is nice. So I want to do immediate loading, immediate implant placement. I want to get immediate nice result. What I have to study to do this? Because if I want to have immediate success, I have to know everything in advance. So I have to control in a very, very, very well manner the levels of the tissue, the thickness of the tissue, the presence of the bone, to place the implant in the correct position, to know that I can make a conversion of the tissue biotype from thin to thick, and very, very, very attention to the abutment design. What I want, what I have in mind every time I work is this design, this picture. This was published the first time a lot of years ago, I believe 40 years ago, by Peter Scharer, and it shows very well what we have in mind to reach when we work in the frontal area. Some authors, many years after, publish some criteria with which we have to see at our work to judge it and to give a vote to our job, so we can say, yes, this is a very nice job, not only for our perception, but also respecting a graduation, a real graduation. Measure, Furhauser, a lot of people publish something similar. Closing to our point, We have a patient. Think that we have to extract the same tooth to these three different patients, the left central incisor. What do you see in this picture? You see that in the first one on the left, the margin is apical, the margin in the center is in the same level, and in the right one is incisal to the adjacent tooth. So we have to take in mind that if I extract the tooth, normally I have a recession of the tissue. So the first case will become worst anymore, and the other one will become the same level, and the central one could be damaged by the extraction. So two are not favorable and one is favorable. I have to decide what to do. I have to move the tissue down. You have already seen the first case at the beginning of the lecture. In the other side, what I can do? Now I have the answer. At the time, I didn't have the answer. Now is to place an immediate implant with immediate restoration and to place the new margin of the new restoration in the exact level position that I want it would be in the future. Then the tissue will move in this direction as I want. But at the time, I didn't know. How can I judge the tissue? I can place a probe. If I look at the probe, the tissue are thin. If I don't look at the probe, the tissue are thick. And this is important because thin tissue is difficult to manage. But I know that I can change the biotype. So I'm already able to tell to the patient, I need to harvest some tissue from your palatal and to put the tissue to change your biotype. I have to give a look to the root, if they are prominent or palatine. It can be easy or worse. The shape of the teeth, triangular, long papilla, it is very difficult to maintain. Quadrangular is easy. And now it is the time to speak about the bone. Gargiulo in 60 talk about biological width. Herman in 2001 wrote about peri-implant width. Is a concept that we have to know because if we don't know where is the bone, where we have to deal with the bone, we cannot reach ideal result. Coyce in the 94 give a new idea. He speak about dentogingival complex. It was for prosthetic purposes article, but we can use it also for the implant. So we can see that most of the patients have a distance from the free gingival margin to the bone of 3 millimeter. 2% of patients less, and 13% of the patient more than 3 millimeters. What is the news? It is that if we are in this situation, the gingival margin will remain most of the time stable. If we move in this situation, almost stable. And if we move here with the bone far away from the free gingival margin, not always it remains stable. So it told us that we have to avoid a long path from the free gingival margin to the bone. And this is true. So when I extract a tooth, I always control where is the crest, and most of the time the crest is at 3 millimeters from the parabola. Every time the crest is there, every time I do what we will see in the future, I have a stable result. So another thing that I have to control is the interproximal peak presence. If the interproximal bone peak is there in the correct position, every time I have the papilla well represented. Fratello Salama brother published many years ago a very interesting article, and they describe very well the distance from the peak to the apex of the papilla, and most of the time we can respect this study, and it's very useful. So every time that I place an implant, and as you can see, the bone peak is in correct position, both mesial and distal, at 10 years or more from the surgery, the papilla is in the right position and the parabola is very nice. Every time I do this. But not always the bone is in the correct position. And so a question that arises very easy is, can I do immediate implant with immediate regeneration? Also in this case, the literature helps us, and the literature says that every time I have a good primary stability, I can do everything in the same time, in the same way, independently from the membrane, type of the membrane that I use. So I have done a lot of cases like this. I extracted the tooth, I place the implant, the bone is missing, as you can see. I place some bone substitute, a resorbable membrane. This is a cross-linked collagen membrane. Suture, provisional, 10 days after, 3 or 4 years after in the right image. But the best is to see the CBCT. The CBCT show very well how much bone is around the implant. Show very well that immediate implant with immediate provisionalization, with immediate regeneration is possible. And there is also a beauty in gray. I have already told you in a certain way how deep I place the implant. Remember the Coy's paper? I place the implant where? Where the crest, the bone crest is. So 3 millimeters above the free gingival margin. Above the free gingival margin that I want, because sometimes the free gingival margin is not in the right position. So I decide to move it. And I will place the implant in the position that I want, not where it is the crest now. So I have to decide if the patient is an ideal patient with a correct parabola, 3 millimeters above the parabola. If the parabola is not in a correct position, I have to move it, and consequently the implant will be moved in that direction. And here is something nice in my opinion, because not all the implants have the same attention to their product. This is the mounter. As you can see, there are 2 notches, colored orange notch, and from the neck of the implant to this point, we have 3 millimeters of distance. So every time I place the implant inside a socket, what I'm able to do, I'm able to place the implant until this point. When this point reaches the apex of the parabola, I stop to screw the implant because I've reached the ideal position. And it is a very useful tool, because if you don't have it, you have to remove the mounter, you have to control with the probe the position of the implant, and for me it's not so easy. Today I have changed a little bit my implant position. I placed it a little bit slightly into the bone, so subcrestal. So from 3, I passed to 4 millimeters above the free gingival margin. I do this every time it is possible. I have seen in the literature that every time you place the implant a little bit subcrestal and you use implant with the platform switch and the concave abutment technique, the bone remains very stable. And I have observed on my patient that this theory is correct. So how deep? I've said about how deep in the neck region, but we have also to place how deep in the apex region, and how deep? Enough to reach a primal stability. So when it's possible, over the position of the precedent root to get primary stability, and depending on the amount of the bone that we have, when possible. Another thing to take into consideration is we have 5 minutes more, is the direction, the bacolingual direction of the implant. If I place the implant to buccal, this plate of bone will remain too thin, and if it remains too thin, it has a tendency to recession, and with its recession, we lose the parabola. So the tooth will become longer than what we want. So we do a mistake. If I place the implant in the center of the socket, the bone will remain well represented and the healing will be good, but it would be almost impossible to do a screw-retained crown. Yes, we can use angulated abutment to do this, but if we don't want to use angulated abutment, it's better to place the implant like in this draw. In this draw is a little bit extreme represented in a higher manner what I want to say, but I like to place the implant with a palate direction because I want that my screw of the screw retained crown will arise in the cingulus, that is this area that you can see with my laser. Every time I do this, in the frontal area will remain a lot of bone, and a lot of bone has a good trophin, and if it has a good trophin, it remains stable over time, and my margin will remain very, very, very stable and pleasant in the ears. There is an article from Uli Grundel and co-authors that show very well that it is important to have at least 2 millimeters of bone around the implant, because every time we screw a restoration or we cement a restoration to the implant, it will form a little crater all around the implant. And if we have the bone, the crater remain inside the bone crest. If we don't have enough bone in the frontal area, this crater create recession and consequently recession of the parabola, of the gingival parabola, and so our result will not be okay. In this picture, it's easy to see the red line. At school, they have learned me to place the implant in this direction on the long axis of the tooth, but now I prefer to use this direction. From this design, I pass to this one. I can extremize the concave design of my components, and I have more space for the bone to remain stable. The only risk that I have in doing this is that sometimes the buccal plate has a concave design and my implant can goes out from the socket. It's not a problem. I regenerate this area, or I change my treatment plan and I start regenerating the buccal bone plate, and in a second time I place the implant. In every case, I'm sorry, I forgot a thing. I have a lot of cases like this one, in which I don't have bone, or better, I don't see the bone in the CBCT, in the buccal part of the implant, but they are very stable. It passes a lot of years, and I see that the tissue remains stable. So there is something that we have to change in our mind. In every case, an image like this one logically gives me more confidence. I prefer to see this. To be sure to place the implant in the right position, we have to use some tools that are very precise in cutting the bone, like this drill. It's a very pointed drill, and it remains very, very, very precise also in a situation like this, that we are in the middle septum of a molar. Or we can use a piezoelectric surgery. We are always in the septum of a molar, and with the piezoelectric, we are able to remain fixed in the position. And then we can use something else to expand the bone, like Versa drill. And from a little hole like this, is a very, very slow, my pointer, like this, with the Versa bar, we arrive to expand the bone and now to be able to place the implant. If we place to buckle the implant, this is the result. These are many patients that I saw in my office. If I place in the medium line of the socket, it will be impossible to do a screw-retainer crown, or you have to do an angulated abutment. So in this case, I prefer to use a cemented crown. If we do a correct surgery, I place the implant with the lingual or palate direction, the result will be very stable over time, like in this situation. You can see very well the concave design. Around this concavity, there is a lot of bone, a lot of soft tissue with a very, very high trophies, and they remain stable over time in a very nice manner, like you can see in this picture. More than 10 years that I do this. I have to respect the bone. With the use of the mine instrument, I can respect this bone. I have to give a distance of at least 1.5 millimeters between the implant and the adjacent root. If I go too close to the root, I lose this bone crest, and if I lose the bone crest, I lose the papilla. And you can see the implant is correct positioned, the bone peak is present here and here, and after a few years, the papilla is in the right position in the mesial and in the distal area. And with this, I'm almost in time. I finish the first part of my lecture, and after the question, we will see again in 7 days. And if you are